Welcome everybody. With you Dr. Magdy Abdel, consultant of infectious diseases, hepatology, and gastroenterology. Our topic today about respiratory syncytial virus. This virus is the single most common cause of respiratory hospitalization in infants, and reinfection remains common in later life. It is an important pathogen in all age group. Infection rates are typically higher during the cold winter months, causing bronchiolitis in infants, common colds in adults, and more serious respiratory illness such as pneumonia can lead to in the elderly and immunocompromised may lead to severe pneumonia. Respiratory syncytial virus is spread through contaminated air and can cause outbreaks both in the community and in the hospital settings. Following initial infection via the eyes or nose, the virus infects the epithelial cells of the upper and lower airway, causing inflammation, cell damage, and airway obstruction. A variety of methods are available for viral detection and diagnosis of respiratory syncytial virus, including antigen testing, molecular testing, and avoiding and viral culture also. The main prevention measures include hand washing, mask wearing, and avoiding close contact with infected individuals. Prophylactic use of Balivizumab is also available to prevent respiratory syncytial virus. Infection in high-risk infants. Currently, there is no vaccine against respiratory syncytial virus, although many are under development. Treatment for severe illness is primarily supportive, including oxygen therapy and more advanced breathing support with CPAP or nasal high flow oxygen as required. In cases of severe respiratory failure, intubation and mechanical ventilation may be required. Ribavirin is the only antiviral medication currently licensed for treatment of respiratory syncytial virus in children, although its use remains controversial. So, as regards signs and symptoms of respiratory syncytial virus, the infection can present with a wide variety of signs and symptoms that range from mild upper respiratory tract infections to severe and potentially life-threatening lower respiratory tract infections, requiring hospitalization and mechanical ventilation. While respiratory syncytial virus can cause respiratory tract infections in people of all ages and is among the most common childhood infections. Its presentation often varies between age groups and immune status. Reinfection is common throughout life, but infants and the elderly remain a high risk for symptomatic infection. As regards children, most children will experience at least one respiratory viral infection by age 2. Most childhood infections are fairly self-limited with typical upper respiratory tract signs and symptoms such as nasal congestion, runny nose, cough, low-grade fever. As regards the inflammation of the nasal mucosa, which is rhinitis, and the throat, pharyngitis, as well as redness of the eyes, conjunctival infection, may be seen on examination. Approximately from 15 to 50% of children will go on to develop more serious lower respiratory tract infections, such as bronchiolitis, viral pneumonia, or croup. Infants are at the highest risk of disease progression. Bronchiolitis is a common lower respiratory tract infection characterized by inflammation and obstruction of the small airways in the lungs, while several viruses can cause bronchiolitis. The infection is responsible for about 70% of cases. It usually presents with 2 to 4 days of runny nose and congestion, followed by worsening cough, noisy breathing, tachypnea, this is called fast breathing, and wheezing. As infants work hard to breathe, they can also show signs of respiratory distress, such as subcostal retractions, intercostal retractions, grunting, and nasal flaring. If the child has not been able to feed adequately, signs of dehydration may also be present. Fever may be present, but high-grade fever is uncommon. Crackles and wheezing can often be heard on auscultation, and oxygen saturation levels may be decreased. In very young infants under 6 weeks of age, and particularly in premature infants, signs of obstruction and signs of infection may be less specific. They may have minimal respiratory involvement. Instead, they may exhibit decreased activity, irritability, poor feeding, or breathing with difficulties. This can also be accompanied by apneic spells or brief pauses in breathing. As regards the adults, reinfection with respiratory syncytial virus remains common throughout life. Reinfection in adulthood often produces only mild to moderate symptoms, indistinguishable from common cold or sinus infection. Infection may also be asymptomatic. If present, symptoms are generally isolated to the upper respiratory tract: runny nose, sore throat, fever, malaise. In the vast majority of cases, nasal congestion precedes the development of cough. In contrast to other upper respiratory infections, the infection is also more likely to cause new onset wheeze in adults. Only about 25% of infected adults will progress to significant lower respiratory tract infection, such as bronchiolitis or tracheobronchiolitis. While infection very rarely causes severe disease in healthy adults, it can cause significant morbidity and mortality in the elderly and those with underlying immunocompromised or cardiopulmonary disease. Older adults have similar presentation to younger adults but tend to have a great symptoms severity with increased risk of lower respiratory tract involvement. In particular, the elderly are more likely to experience pneumonia, respiratory distress, and death. Thank you very much.